Hello, I'm Rita Campos with the UCB US Medical Affairs team, and I'm here today on behalf of UCB to take you through the midazolam nasal spray data that supported the FDA approval. Thank you to the ALAT Organizing Committee for the opportunity to speak here today. This is my disclaimer, and I'd like to particularly emphasize our thanks to the patients, their caregivers, and the investigator teams who contributed to these studies. Midazolam nasal spray was approved by the FDA in May 2019 for the acute treatment of intermittent stereotypic episodes of frequent seizure activity, such as seizure clusters and acute repetitive seizures, that are distinct from a patient's usual seizure pattern in patients with epilepsy 12 years of age and older. It's a midazolam formulation designed for nasal delivery in the outpatient setting that can be administered by a non-healthcare professional during a seizure cluster by administering one 5 mg spray in one nostril. If the patient hasn't responded to the initial dose, one additional spray of 5 mg may be administered after 10 minutes in the opposite nostril. No more than 2 doses should be used to treat a single episode, and it is recommended that midazolam nasal spray be used to treat no more than 1 episode every 3 days, with a maximum of no more than 5 episodes per month. Midazolam nasal spray was studied in a multinational phase 3 randomized, double-blind, placebo-controlled trial called Acute Rescue Therapy in Epilepsy with Midazolam Nasal Spray, aka Artemis-1. Its objective was to evaluate the safety and efficacy of midazolam nasal spray compared with placebo in the outpatient treatment of patients with epilepsy experiencing a seizure cluster. The study was conducted in 2 phases, an open-label test dose phase, followed by a double-blind placebo-controlled phase. The test dose phase occurred in clinic under HCP supervision while the patient was not having a seizure, and tolerability was assessed in 292 patients who received 2 5 mg doses of midazolam nasal spray, separated by 10 minutes for a total dose of 10 mg. The patients were evaluated for safety criteria and, if appropriate, were allowed to progress to the subsequent double-blind comparative phase, where midazolam nasal spray efficacy was compared with placebo in the outpatient setting. 262 patients were randomized in a 2-to-1 ratio to this phase, and 201 patients received double-blind treatment to treat 1 seizure cluster. If the seizure cluster did not terminate within 10 minutes, or if there was a recurrence of seizures within 6 hours, patients could then receive an open-label optional dose as long as the patient did not exhibit signs and symptoms of cardiorespiratory depression. 1 to 5 days post-dose, the patient would return to the investigator site for the post-dose assessment. Patients included in the trial were aged 12 years or older and had an established diagnosis of partial or generalized epilepsy, were on a stable regimen of antiepileptic drugs, and had a documented history of seizure clusters, and were also required to have a competent adult caregiver able to recognize a seizure cluster and willing to be trained in the study procedures and to administer the treatment. In terms of the baseline characteristics of the patients in the clinical trial, demographics and disease were similar in both treatment arms. For the patients in the midazolam nasal spray treated arms, select baseline characteristics included a median age of 32 years and a typical baseline seizure cluster consisting of a median of 5 seizures and lasting for just over an hour. In the double-blind phase of the trial, each patient was treated for a single seizure cluster episode and received either a 5 mg dose of midazolam nasal spray or placebo. Treatment success was the primary endpoint and was defined by 2 components. First, the termination of seizures within 10 minutes after the double-blind dose was given, and second, no recurrence of seizures between 10 minutes and 6 hours. To meet treatment success endpoint, the patient had to meet both of these criteria. When accounting for both components of the primary endpoint, the percentage of patients achieving treatment success with a single dose of midazolam nasal spray was 53.7 versus 34.3 in the placebo group, for a statistically significant difference. Additionally, as a secondary endpoint, the study also evaluated the occurrence and time to next seizure after the initial blinded dose of study drug. Based on a Kaplan-Meier analysis, midazolam nasal spray treated patients had a greater probability of not experiencing more seizures for 24 hours post-dose, with an apparent separation between the midazolam nasal spray and placebo curves being apparent from 30 minutes post-study drug administration. During the trial, caregivers also recorded actual seizure recurrence within 24 hours post-dose, with 37.3% of midazolam nasal spray treated patients experiencing a next seizure within 24 hours after the double-blind study drug administration versus 46.3% in the placebo group. Analyzing the Kaplan-Meier curve on probability of no seizure recurrence for 24 hours post-dose, patients treated with midazolam nasal spray were significantly less likely to experience seizures versus placebo. Time to return to full baseline functionality after study drug administration was also evaluated as an exploratory endpoint. For all seizure clusters treated with midazolam nasal spray, the median time to return to full baseline functionality after trial drug administration was approximately 90 minutes, which was comparable to placebo. Functionality was assessed and determined by the caregiver and defined as the patient's ability to return to the activity they were doing prior to the start of the seizure cluster. A significantly greater proportion of patients treated with midazolam nasal spray returned to full baseline functionality within 24 hours of study drug administration when compared to those treated with placebo. Up until now, we've focused on treatment success after only the double-blind dose of midazolam nasal spray or placebo. However, an optional open-label second dose of midazolam nasal spray was possible to administer if needed. Approximately 31% of midazolam nasal spray patients required an open-label dose compared to approximately 61% of placebo-treated patients. Therefore, we also have data on the treatment success with any dose of midazolam nasal spray, which we'll now review. 69.7%, or 122 out of 175 patients, experienced overall treatment success with any dose of midazolam nasal spray, either 1 or 2 doses. Patients were monitored throughout the trial for treatment-emergent adverse events. Most adverse events were mild to moderate in intensity, and 16 patients discontinued during the test dose phase. No notable differences in the incidence of treatment-emergent adverse events between the midazolam nasal spray and placebo groups were observed. Throughout the trial, treatment-emergent adverse events experienced by most patients were not unexpectedly sedation-type events and, given the route of administration, nasal discomfort, which is consistent with the known midazolam pharmacology and midazolam nasal spray route of administration. These results confirm the acceptable safety profile of midazolam nasal spray and support the feasibility of administration by a non-healthcare professional in the outpatient setting. Now, to evaluate safety and seizure-related outcomes with repeated intermittent use of midazolam nasal spray in the outpatient treatment of patients experiencing seizure clusters, a phase 3 open-label extension trial was conducted. Patients who completed the double-blind study were invited to participate. After providing written informed consent, patients underwent screening procedures at visit 1, either at the same time as the last visit of Artemis 1 or up to 28 days after. Patients were to be treated by the caregiver with a single 5 mg dose for a cluster episode. The second 5 mg dose in a kit could be administered if the episode did not terminate within 10 minutes or if another seizure occurred 10 minutes to 6 hours after the administration of the first dose, provided the patient did not have signs and symptoms of cardiorespiratory depression. A minimum of 3 days was required between treated episodes. Data were collected from 161 patients who received treatment for 1,998 cluster episodes over a median observation period of 16.8 months. Overall, criteria for treatment success were met in 86.3% of the treated episodes for which patients received 1 or 2 5 mg doses of midazolam nasal spray. Intermittent use of midazolam nasal spray over multiple episodes did not diminish in efficacy over the number of treated episodes. Results also demonstrated that midazolam nasal spray was well tolerated and was associated with a favorable safety profile. Treatment-emergent adverse events reported by most patients were somnolence and nasal discomfort. Most adverse events were mild to moderate in intensity. Somnolence was consistent with the known pharmacology of benzodiazepines, and events relating to nasal discomfort were not unexpected given the route of administration. There was a low incidence of serious treatment-emergent adverse events considered to be related to midazolam nasal spray. Now, as a summary, after the double-blind dose of midazolam nasal spray, 53.7% of patients experienced treatment success compared to 34.3% of patients who received placebo. Patients treated with midazolam nasal spray were significantly less likely to experience further seizures within 24 hours compared to placebo. In the Artemis-1 study, the median time to return to full baseline functionality after administration of midazolam nasal spray was 1.4 hours for all treated seizure clusters. The overall rate for treatment success for any dose of midazolam nasal spray was 69.7% for patients who received midazolam nasal spray in the comparative phase. And as a summary for the comparative phase, the safety profile of midazolam nasal spray was consistent with the known pharmacology and route of administration. Midazolam nasal spray was well tolerated during the comparative phase. There were no patients with acute central respiratory depression and no discontinuations due to treatment-emergent adverse events. The most common treatment-emergent adverse events in the comparative phase were nasal discomfort, somnolence, throat irritation, and headache. Most treatment-emergent adverse events during the comparative phase were mild to moderate in intensity. This concludes my presentation. Thank you for your time and attention, and I will now take questions.
Thank you, Dr. Campos. Good to have you on board again. We have plenty of questions from the audience. And I'll start with two anonymous attendees. Question number one, was the difference between the drug and placebo significant at 10 minutes after dosing?
So for the first component of our primary endpoint, there was a numerical difference in favor of midazolam nasal spray, not statistically significant.
Thank you. Second question, how many patients were on concomitant use of other benzos such as clobazam?
From memory, I would say it was 9 patients, thinking about the TFLs, but most benzodiazepines were actually one of the exclusion criteria and had to be discontinued 3 days prior to being dosed.
Okay, a question from Professor Torbjörn Thompson. In the Artemis-1 study, what was your justification for the use of placebo rather than active control, considering the issue of delaying active treatment of seizure cluster by 10 minutes?
Well, not having the full story behind the design of this protocol, as you very well mentioned, this was developed by Proximogen. I can only interpret this as the intended indication would be to be a standalone treatment, not necessarily an adjunctive treatment. But again, this is my speculation, and I can't speak necessarily to the full design agreed with the FDA. It seems to me that from those discussions that the FDA agreed that this would be the ideal design to have a treatment for the outpatient setting in this particular disease state, seizure clusters, acute repetitive seizures. And therefore, this was what was agreed and later on put in practice in the phase 3.
Thank you. And there's a question from D. Perez. What is the list of excipient in the midazolam nasal spray? For example, some formulation of buccal midazolam ethanol is one of the excipients. Is it the same for the midazolam nasal spray?
I'll have to be very honest. I don't know the full list of excipients, but I'm happy to follow up on this question. Makes me a bad pharmacist, so be it.
Listen,
I don't have it top of mind.
Rita, we are colleagues. I'm a pharmacist too, so don't feel shy, please. I will give you a pharmacist question, if I may.
Okay.
What's the maximal? Same questions I asked Enrique, the previous speaker. Mm-hmm. What's the maximal volume you can give intranasally with your midazolam nasal spray? Is it 100 microliter, like was mentioned by the previous speaker?
Yeah, 0.1 milliliters is what is in each dose.
And since your active ingredient, thank you for the demonstration. Since your active pharmaceutical ingredient, midazolam, is the only water-soluble benzodiazepine, I presume, and please correct me if I'm wrong, that your vehicle is aqueous with no enhancer or solubilizing agents in the case of the intranasal spray of midazolam?
But actually, in this formulation, midazolam is practically insoluble in water, and it is by this particular configuration of the imidazole ring that it manages to cross that nasal mucosa and reach serum levels in 5 minutes. So it is not water soluble in this particular case for this adjusted formulation, specifically designed for nasal delivery.
Thank you. Piero, do you have any questions from your side?
Yes, maybe I'll just scroll through the questions from the audience. Thank you, Dr. Campos. One is relevant to clinical practice. Are there any plans to have nasal and nasal spray licensed in the UK?
Aha. I was expecting a similar question. What I can say is that currently UCB is very much focused on ensuring that it is available for the US patients and accessible to the US patients, namely in every pharmacy across the US, and also assessing all options outside of the US. We currently have made no decisions, but we are taking every scenario into consideration to make sure that we can reach as many patients that have the need for this drug.
And what can you tell us if you compare your intranasal spray to the buccal midazolam that is available at least in the UK?
Well, we don't have head-to-head studies, so it would be inappropriate for me to make comparisons, direct comparisons. And again, we have very much focused on the US side, so I can't necessarily give you that much information around even indirect or looking at data comparisons. I know it won't satisfy your curiosity. It is my limit.
Okay, thank you very much, Dr. Campos.
Thank you.
If you can stay with us, and thank you also for the other speakers. And I guess now we have a break of 10 minutes, and or maybe we'll ask other speakers like Dr. Karazana and Dr. If you can kindly join us for a general discussion after this session, please. And Piero, if you have any questions to the other, or if there are any questions that were asked by attendees that we have not answered.
Yes, no, I think we should have just a brief general discussion before the break, Mayor. So we had lots of questions for Dr. Nguyen, but I think he has left, so I don't see him. But we have a question for Dr. Campos.
Go ahead.
Can midazolam nasal spray be used in the aura stage of a seizure?
In the aura stage of the seizure, yes, it can. It has a broad indication. Yeah, it has a broad indication. It was tested, as far as I understood from the results of the trial, looking at the demographics in all types of seizure clusters that include aura. Yes.
Great. Mayor?
Yes, I just got a comment from Mike Rogowski. He tries to help you. You see, he says that the pH.
Thank you.
As we say, good people, righteous people, their good deeds are done by somebody else. So here is Mike Rogowski, and he just
paying it forward. Thank you, Dr. Rogowski.
He alluded to the fact that the pH of your intranasal spray has to be neutral. In such a neutral pH, indeed, midazolam is not insoluble in water. It's soluble only in a more acidic one. And if you go down with the pH, it's more irritating to the nasal spray. So I wanted to, to deliver Dr. Rogowski's message in that regard. We have, I think there are some other questions that have not been answered for other speakers. Your major indication, by the way, Dr. Campos, is for acute repetitive seizure. What's the major kind of seizures you are aiming? Is it the similar what Enrique was referring earlier about prolonged or continuous seizures, or it's more to the acute repetitive seizures?
So our indication is the intermittent stereotypic increased bouts of seizure activity, which will include whatever that stereotypic seizure cluster, acute repetitive seizure profile is. There is no limitation to that necessarily. However, we are not indicated for prolonged seizures or additional seizure emergencies.
I also have a question, Mayor, if you don't mind. You mentioned, Dr. Campos, that a proportion of patients were on clobazam, or at least another vendor.
9 patients,
have you analyzed the data separately for those on clobazam versus those who were not?
So the sample size is very small. We have not done a specific post hoc on that specific population. We have looked at, there are 9 patients, but of course, this being an orphan designation, it's always a limited number of patients. I can't tell you anything about that currently. We might consider that for future post hoc analysis for sure.
And the other question I had, Mayor, if you don't mind, still for Dr. Campos, who we're just bombarding with questions, is, I mean, in terms of next step, future planning, are you looking potentially at assessing the efficacy in seizure clusters, in particular epilepsy forms? One that comes to my mind is a genetic form of epilepsy with seizure clusters related to a mutation in PCDH19. Cardiac epilepsy, and this form of epilepsy has seizure clusters often triggered by fever. But are you planning to explore the efficacy of your product in specific epilepsies?
At this time, we are not. We are focused really on making sure that the current formulation is made available to as many acute repetitive seizure cluster patients as possible.
Thanks, and I hope Australia as well.
Enrique, is there
if I can launch it there, I will be the one driving it.
I'll give you a break and I'll ask a question, Enrique, but I have one more for you, you know. Enrique,
okay.
What else can you elaborate on your auto-injector, you know, with the enhancer, the interval, etc.? You still don't have a primary indication in terms of the seizures that you are aiming with your...
We're aiming essentially for prolonged seizures. So essentially any seizure that lasts longer than 5 minutes. It will be an intranasal, so the device will probably be very similar to Valtoco, which is actually very similar to the Nasalam device. It's an Aptar device. It's a single dose device. There's no difference between them.
Now I'm helping you.
There's no difference between the devices. They're Aptar devices.
There is a question that may be is applicable to both of you. If you can use, from the attendees, if you can use either one of these nasal spray in Aura, what do you think on that, Rita?
For midazolam nasal spray, Nasalam, yes, you may.
And what do you say, Enrique?
Likewise, in Study 05, which is a long-term study in which we had over about 180 patients for about 4 years, we had a number of patients, actually a significant number of patients who self-administered the drug during the beginning of the seizure, i.e. the aura. Again, all related to seizure clusters, obviously.
Yes, of course. Same here, well within the seizure cluster profile.
Shall we pause for a break, Piero? Okay. Thank you, Dr. Campos. Thank you, Dr. Carazana, for excellent participation.
Thank you.
Also, thank to your companies for the support to the ELAT 15 conference. And we'll now pause till about 7 o'clock for a coffee break, etc. And I look forward to have you, all of us, with us. Thank you very much. See you soon. Bye-bye.